Hello everyone. Today we are going to learn one more important topic, that is hypocalcemia. So normal serum calcium is 8.5 to 10.5 milligram per deciliter, which includes ionized calcium, which is free or active form of calcium. And rest of the calcium is bound to albumin and phosphate and citrate and another other inorganic ions. So basically ionized calcium is active form of calcium. So what is normal serum calcium level? Normal serum calcium level is 8.5 to 10.5 milligram per deciliter, in which ionized calcium is 4.65 to 5.25 milligram per dl. So when we call it as hypocalcemia, when serum calcium is less than 8.4 milligram per deciliter with normal serum albumin. Normal serum albumin is very important. So serum calcium less than 8.4 milligram per deciliter, but requirement is serum albumin should be normal or an ionized calcium should be less than 4.2 milligram per dl when we call it as hypocalcemia. So serum albumin has very important role in physiology of serum calcium, which we will discuss it later. So what are the things that are responsible for the calcium regulation in our body? The most important is hormonal regulation. So what are the various hormones which control calcium levels in our body? So first and most important is parathyroid hormone. Parathyroid hormone and vitamin D has a very crucial effect in regulation of calcium. So parathyroid hormone and vitamin D regulate serum calcium level via effects on bone, kidneys and GI tract. So if there is hypocalcemia, PTH increases the bone resorption, resulting into increase in serum calcium levels. So it will result into increased resorption of calcium from bones. Secondly, it increases the absorption of vitamin D3 from GI tract. And what is its effect in kidneys? It will increase the conversion of calcidiol, that is inactive form of vitamin D, to active vitamin D. So mainly the serum calcium is maintained within normal range by parathyroid hormone and vitamin D. What is the effect of parathyroid hormone? Parathyroid hormone acts on mainly bones, kidney and GI tract to maintain the normal calcium levels in our body. So vitamin D, it increases the intestinal calcium reabsorption in case there is hypocalcemia, or it also helps in maintaining normal physiology of calcium. Next important thing is FGF23. So this FGF23 is another mediator which helps in regulation of calcium ion. It is released in response to increased phosphate, mainly in patients of CKD or chronic kidney disease. So this FGF23 is released in response to increased phosphate, but this FGF23 also inhibits the conversion of vitamin D to active form, thus decreasing calcium reabsorption. So one important parameter was parathyroid hormone, which increases the serum calcium, then vitamin D3, and then there is FGF23, which is released in response to increased phosphate ions. Mainly it is released in patients of CKD where there is hyperphosphatemia, but it also inhibits the conversion of vitamin D to active form, so ultimately decreasing calcium reabsorption. So next important mediator is calcium sensing receptor. Calcium sensing receptor is very important. It is present in parathyroid glands as well as loop of Henle. It auto-regulates the calcium whenever there is hypercalcemia. It is activated and it decreases the parathyroid hormone release from parathyroid glands. So whenever there is hypocalcemia, calcium sensing receptors will be activated. They release parathyroid hormone immediately. Instantly, parathyroid hormone is released from parathyroid gland. Parathyroid hormone has three actions. It increases the calcium reabsorption from distal convoluted tubules. Plus, it increases the renal production of active vitamin D. Then it increases the bone resorption. And thus increases the serum calcium levels. So calcium sensing receptor is very important. It auto-regulates the serum calcium levels. So calcium sensing receptors are activated in presence of hypocalcemia and results into release of PTH secretion immediately. But if there is hypercalcemia, it is sensed by calcium sensing receptor. They inhibit the parathyroid release from parathyroid glands and also increases the secretion of calcium from loop of Henle. So it has dual actions. It helps both in hypo as well as hypercalcemia. So this is the normal physiology of calcium level, how it is regulated in our body. So mainly there are four mediators which helps in calcium regulation: parathyroid hormone, vitamin D3, FGF23 and the calcium sensing receptors. So now coming to etiology of hypocalcemia. So before going into etiology of hypocalcemia, we should think about two main things. The first is albumin level. Around 30 to 40% of serum calcium is bound to albumin. So we should look for serum albumin level before labeling it as hypocalcemia. So for every we should correct the calcium level for hypoalbuminemia. The formula is 0.8 into 4 minus 1 plus the serum calcium. Next thing, we look for acid base disturbances. So first, hypoalbuminemia is very important. We should correct the calcium for low albumin level. Formula is 0.8 into 4 minus 1 plus the serum calcium level of the patient. Next thing is acid base disturbances. So in the presence of normal albumin levels, the total serum value which we have obtained cannot be used for correction sometimes, because if there is acidosis in the body, there will be greater release of albumin from calcium, and in case of alkalosis, there is problem in dissociation of the albumin calcium complex. So in surgical patients or critically ill patients in which there is respiratory alkalosis, the total serum calcium level cannot be used to correct the calcium. Then we have to look for the ionized calcium. So we have to directly measure the ionized calcium. So two things are very important before we labeling the serum calcium level as hypocalcemia. First is hypoalbuminemia. The total serum calcium levels should be corrected for degree of hypoalbuminemia. And second is acid base disturbances. In case of alkalosis, mainly in case of respiratory alkalosis, the albumin calcium complex is not dissociated, resulting into low level of ionized calcium. So we have to directly measure ionized calcium. So first we look for hypoalbuminemia, then acid base disturbances. So now coming to the main etiologies of the hypocalcemia. So we have already discussed the important mediators in regulating the calcium level, that is parathyroid hormone. So parathyroid hormone is very important in calcium regulation. So in case of low PTH, there will be hypocalcemia. So we should look for the etiologies that are responsible for low parathyroid hormone. Next is vitamin D deficiency. That is very important. In CKD patients, there is hypocalcemia. There are multiple reasons for that, but mainly main reasons can be hypoparathyroidism, vitamin D deficiency. So hypocalcemia with hypoparathyroidism. So what are the causes of hypoparathyroidism here? It can be seen as a complication of thyroidectomy. It can be seen after the treatment of Graves' disease after iodine 131 therapy. There can be autoimmune hypoparathyroidism. One important thing you should always remember in your mind before correcting hypocalcemia, that is the serum magnesium level. Serum magnesium level is very important. Whenever you will see a patient of hypocalcemia, if the calcium is not getting corrected, despite of giving IV or oral calcium, one should always see for magnesium levels. So hypomagnesemia is a very important cause of hypocalcemia. It results into hypoparathyroidism and hypocalcemia. So likewise in hypokalemia also, if hypokalemia is persistent despite giving IV potassium chloride, we should look for magnesium levels, which can be the culprit for hypokalemia as well as for hypocalcemia. Next thing we should look for, so the cause of hypocalcemia with hypoparathyroidism can be, it can be seen as a complication of thyroidectomy, or it can be seen in patients with Graves' disease after iodine 131 therapy. They can be autoimmune hypoparathyroidism, and hypomagnesemia is very important. So three things you should always keep in your mind before correcting hypocalcemia, that is albumin level, acid base disturbances, especially respiratory alkalosis, and third is hypomagnesemia. Magnesium is very important. So next cause of hypocalcemia is vitamin D deficiency. Vitamin D deficiency can be low in case of decreased dietary intake, inadequate sun exposure, or reduced active form of vitamin D. It can be seen in CKD patients. The 125 hydroxylase enzyme is present in renal cells. So in case of CKD patient, there is decreased synthesis of active form of vitamin D, resulting into vitamin D deficiency and hypocalcemia. So in CKD patient, we have in CKD patient mostly we will see hypocalcemia because of vitamin D deficiency. So vitamin D deficiency is one of the important cause of hypocalcemia in CKD patients. And increased level of FGF23, which we have already discussed, increased phosphate levels. So these are the main reasons why there is hypocalcemia in CKD patient. But one most important thing is, in CKD patient there will be secondary hyperparathyroidism with hypocalcemia. So hypocalcemia with secondary hyperparathyroidism is seen in CKD patient. We have discussed hypocalcemia with hypoparathyroidism, but in CKD there will be hypocalcemia with secondary hyperparathyroidism. So hypoparathyroidism, vitamin D deficiency, secondary hyperparathyroidism. In miscellaneous causes, we have pancreatitis, which results into hypocalcemia, hungry bone syndrome. In multiple blood transfusion, there can be citrate containing blood, there can be citrate calcium complex, resulting into hypocalcemia. And like we have already discussed, respiratory alkalosis results into decreased ionized form of calcium because of less dissociation of albumin calcium complex. So in critically ill patients, we should directly measure the serum ionized calciums. Then hyperphosphatemia is also an important cause of hypocalcemia. Osteoblastic metastasis results into hypocalcemia. So all these causes, you should rule out all these causes whenever you evaluate a patient of hypocalcemia. So these are the main things which can result into hypocalcemia. Now, how we will diagnose a patient of hypocalcemia? What are the clinical presentation? What are the various clinical presentations in which a patient of hypocalcemia can present? So the signs and symptoms of hypocalcemia depends upon the severity, whether it is acute or in chronic. In acute severe form, patient can have tetany. What is tetany? It is just neuromuscular irritability. Tetany can be mild or it can be severe. So in mild form of tetany, there can be perioral numbness, paresthesias of hands, feet, and muscle cramps can be present. But in severe form of tetany, tetany is life-threatening. So patient can have laryngospasm, carpopedal spasm. We can present with seizures, focal or generalized. So hypocalcemia, the signs and symptoms, the clinical presentation depends upon the severity, whether it is acute or whether it is chronic. If it is acute, severe, then it can present with tetany. Tetany is neuromuscular irritability. It can be mild or severe. In severe form, patient can present with acute breathing difficulty. There can be laryngospasm, carpopedal spasm. There can be focal or generalized seizures. So what are the signs of the latent tetany? First is Trujillo sign and Chvostek signs. So Trujillo sign is, how can we elicit the Trujillo and Chvostek sign? Trujillo sign is elicited when you inflate the PP cuff above the systolic pressure for more than 3 minutes, then there will be carpopedal spasm. That is called Trujillo sign. Trujillo sign and Chvostek signs, these are the signs of latent tetany. So Trujillo sign is elicited by increasing the blood pressure by above the systolic BP for more than 3 minutes. And how we can elicit the Chvostek sign? By tapping over the by tapping anterior to the tragus, there will be twitching of the facial muscles. So this is Chvostek sign. Very rarely patient of hypocalcemia can present with papilledema. And there can be psychiatric manifestations like insomnia, anxiety. Patient can have depression. So patient can present with psychiatric manifestations, also insomnia, anxiety, depression. So these are the various ways how can a patient of hypocalcemia can present to you. In mild form, it can be just perioral numbness, paresthesias of hand, muscle cramps, and signs of latent tetany can be present. Trujillo sign and Chvostek signs. These signs are also very important. So how will diagnose that it is hypocalcemia and what can be reason for it? So like we have already discussed, the main reason can be hypoparathyroidism. It can be vitamin D deficiency. It can be hypomagnesemia or chronic kidney disease, or can be parathyroid resistance. So what are the important parameters we should look at the time of diagnosis? Okay. So these are serum parathyroid hormone levels, phosphate levels, magnesium levels, vitamin D levels, and active form of vitamin D levels, and serum creatinine in case of chronic kidney disease patient. So what are our main etiologies for hypocalcemia? Hypoparathyroidism, hypomagnesemia, PTH resistance, vitamin D deficiency, and chronic kidney disease. Only in chronic kidney disease our serum creatinine levels will be elevated. In rest of the things, serum creatinine levels will be normal. In CKD patient, creatinine level will be elevated. So what are the things we will see in hypoparathyroidism? In hypoparathyroidism, PTH levels will be low. Hypoparathyroidism, so phosphate levels will be elevated. Serum magnesium will be normal. Calcidiol level, that is inactive form of vitamin D, will be normal. And the active form of vitamin D, either it can be normal or it can be low in case of hypoparathyroidism. Creatinine levels will be normal. In hypomagnesemia, parathyroid hormone levels will be low. Rest of the things will be normal. So talking about PTH resistance, in case of PTH resistance, PTH level will be elevated. Since there is PTH resistance, so there will be decreased secretion of phosphate levels. So phosphate levels will be elevated. So phosphate levels will be elevated in case of hypoparathyroidism, plus whenever there is PTH resistance. But in case of PTH resistance, the parathyroid hormones will be elevated. So there are the two things. hypocalcemia with hypoparathyroidism and hypocalcemia with hyperparathyroidism. So hypocalcemia with hyperparathyroidism, one cause we have discussed, that is CKD, and another is PTH resistance. So in case of PTH resistance, parathyroid hormone levels as well as phosphate levels will be elevated and rest of the things are normal. Next important cause is vitamin D deficiency. So in case of vitamin D deficiency also, there will be secondary hyperparathyroidism. Phosphate levels will be low or normal. Magnesium level will be normal. So there is vitamin D deficiency. So both active and inactive form of vitamin D's were low and creatinine will be normal. So in vitamin D deficiency, there can be normal active form of vitamin D3, because whenever there is vitamin D deficiency, it results into secondary hyperparathyroidism, which results into increased conversion of inactive form of vitamin D to active form. So there can be sometimes there can be, we can see normal 125 hydroxylase vitamin D, but calcidiol is low, but this is normal. So next is chronic kidney disease. In chronic kidney disease, we will see elevated creatinine levels. So there is secondary hyperparathyroidism, so PTH levels will be activated. Phosphate levels will be elevated. Because of elevated phosphate levels and hypocalcemia, there is secondary hyperparathyroidism in CKD patients. Magnesium levels can be elevated or normal, and vitamin D3 levels are usually low in case of CKD patients. So this is the diagnostic workup how we can evaluate for hypocalcemia. So now coming to the treatment part. So now we have diagnosed hypocalcemia. So now how we will treat hypocalcemia. So before treating hypocalcemia, you should always look for certain things that can be a culprit for hypocalcemia. These are the things you should always kept in mind before initiating the treatment of hypocalcemia or giving patients supplements of calcium. So first most important thing is phosphate level. If there is severe hyperphosphatemia, like in patients of CKD, if the serum phosphate level is more than 6.5 milligram per dl, you should directly go to dialysis, because there is hyperphosphatemia and you have given the patients calcium from outside, so there can be ectopic calcium phosphate chelation and there can be ectopic calcification. So if serum phosphate levels are elevated, if there is severe hyperphosphatemia, that is more than 6.5 milligram per dl, most commonly seen in patients of CKD, so you should directly go with the option of dialysis, otherwise you will harm patient. It can result into ectopic calcification. Next thing, you should look for magnesium level, because there is no use of giving patient IV calcium if magnesium is not corrected. So magnesium can be given 2 gram IV stat followed by infusion. So you should look for phosphate level and you should look for magnesium levels. Then coming to calcium supplementation. So before giving calcium supplementation, you should look for serum albumin level, ABG status, or what is the acid base status of the patient. Respiratory alkalosis is present or not. Then serum phosphate levels are more important, and then magnesium levels. After seeing all these things, we will give patient calcium supplements. So whether we have to give IV or oral calcium, it depends upon the etiology and severity of the calcium hypocalcemia, whether it is acute severe form or it is chronic mild form. So in acute severe form, if patient presents to you with seizures or laryngospasm, then give patient IV calcium supplements. It can be calcium gluconate or calcium chloride. So we prefer calcium gluconate because it has less chances of tissue necrosis or if there is any extravasation. So we can give 10 to 20 ml bolus followed by infusion. So this is the acute management of hypocalcemia. Then for chronic management, we can give oral calcium supplements, vitamin D. So oral calcium supplements should be taken away from the meals to decrease the risk to precipitate the calcium with phosphate that is present in meals. So oral calcium supplement should be given away from the meals. Then vitamin D, 60,000 international units once a week should be given for 6 to 8 weeks. Then one important thing for the correction is calcitriol levels. That is, will directly give active form of vitamin D, usually given in CKD patient where there is less conversion of calcidiol to calcitriol. But one important thing with calcitriol, we have to check phosphorus levels. It results into increased phosphate levels. So for chronic management, oral calcium supplements, vitamin D should be given for 6 to 8 weeks, and calcitriol, which is the active form of vitamin D3. So this is all for today. If you like this video, give it a thumbs up and more such videos. And for more such videos, please subscribe my channel. So please subscribe my channel.